Welcome back. Today we are going to be discussing neurodevelopmental disorders, and we are going to explore the classification for each of these disorders, focusing on childhood conditions as well as the causes, both biological and environmental. We'll also review the symptoms that may appear in both childhood and adulthood and examine both short-term and long-term treatment options. When we examine neurodevelopmental disorders, we often refer to developmental psychopathology, which means that many of these disorders we'll discuss today typically have their onset in childhood. Some disorders, like separation anxiety disorder, are unique to childhood, while others, like ADHD and Autism Spectrum Disorder, usually begin in adulthood but do go across the lifespan. Additionally, some disorders like depression and anxiety can occur in both children and adults, so we'll briefly touch upon their co occurrence. Childhood disorders, such as those related to behavior, are classified into two main categories. In the DSM 5, and the first category that we're going to cover today is neurodevelopmental disorders. This second category focuses on disruptive, impulse control, and conduct disorders. So, we're going to explore how neurocognitive disorders are considered alongside neurodevelopmental disorders. Some of the terminology surrounding childhood disorders has changed over time. If you were practicing in the field, say 10 or 20 years ago, you may notice differences in the names we use today compared to what you may have learned during your undergraduate studies. This is certainly true for me and every once in a while. For example, mental retardation, quote unquote, is now referred to as intellectual disability, and terms like Asperger's are no longer used, with autism spectrum disorder now being the preferred term. So these changes were introduced with the publication of the DSM 5. Childhood disorders are varied, with some being developmental in nature, while others, such as anxiety disorders, are categorized differently. These include intellectual disability, specific learning disorders, autism spectrum disorder, motor disorders, communication disorders, ADHD, feeding and eating disorders such as anorexia, bulimia, and binge eating, disruptive and impulse control, and conduct disorder and anxiety disorder. Anxiety disorder in childhood does go beyond separation anxiety disorder and can also include early onset social anxiety and other issues that emerge before age 18, but also before age 12. So, when classifying these disorders, we can examine them in two main categories: externalizing and internalizing. Externalizing disorders are characterized by outwardly direct behaviors such as noncompliance, aggression, hyperactivity, and impulsivity. These disorders are more commonly diagnosed in boys, although that doesn't necessarily mean that they occur more frequently in males. Rather, they are more often observed and diagnosed in boys. On the other hand, internalizing disorders are marked by inward focus, and these are often associated with anxiety and mood disorders. These are typically more common in girls, but they can also occur in males. Gender can sometimes influence the diagnosis, as behaviors that are considered socially acceptable or unacceptable may vary. And this discrepancy is one area where training and awareness are helping to improve the field, especially when it comes to recognizing and diagnosing externalizing disorders more effectively. So, the first disorder that we're going to look at here today is ADHD, attention deficit hyperactivity disorder, and it's characterized by excessive activity such as fidgeting, squirming, or running around. These children may talk nonstop. Teachers may describe them as bouncing off the walls. They are often distractible. They have difficulty concentrating, leading to careless mistakes. For example, a child may only be able to follow one-step instructions rather than two or three-step instructions. You may tell them to go get a cup of milk, but they return to the kitchen with a toy instead, forgetting the milk altogether. So, children with ADHD often struggle with peer interactions, finding it challenging to engage appropriately in social situations. The DSM-5 criteria for ADHD are outlined here on this chart. So, if you'd like to, you can take a moment and pause the video to read through. But to meet the criteria, there must be A or B met with at least 6 months of manifestation of inattention or hyperactivity slash impulsivity present for a minimum of 6 months. This cannot be a one-time occurrence. The symptoms must be observed over time and cause significant impairment in daily functioning. It's important to note that symptoms must be maladaptive, meaning that they interfere with the person's normal life and are greater than what would be expected for this individual's age. For example, while young children are naturally energetic, we must carefully observe whether there are 6 or more signs of hyperactivity and or impulsivity that are maladaptive and persistent. In addition to the inattention, we also consider symptoms like fidgeting, restlessness, and the feelings of kind of being driven like a motor. You'll often hear that as described in the DSM-5. Other signs include incessant talking, interrupting, intruding on other behaviors. These symptoms must be present in at least 2 different settings. This is very important. So it could be at home, at school, at work, and other situations, maybe practice if they play sports, and it has to cause significant impairment. So for children, this includes community settings as well. For individuals 17 and older, only 5 signs of inattention or hyperactivity need to be present for the diagnosis. ADHD often persists into adulthood, although it can improve over time before plateauing. Adults may receive a diagnosis later in life, particularly if they were undiagnosed as children, and this often occurs when children were diagnosed and they recognize uh, they take their child to a mental health professional, the child is diagnosed with ADHD, and then the parents realize, oh, actually, you know what, I have a lot of similar symptoms too. There are 3 specifiers in ADHD, predominantly inattentive type. This is characterized by forgetfulness and difficulty focusing, predominantly hyperactive slash impulsive type. This includes impulsive actions such as rushing across the street without looking or pushing another child impulsively without understanding the consequences or even taking a moment to think about them. And then combined type, which is both inattentive and hyperactive symptoms, which are present. And that is the most common type of the ADHD specifiers. Differential diagnosis are important in distinguishing ADHD from other conditions. For example, when children get older, ADHD can be confused with conduct disorder. To differentiate, ADHD typically involves cognitive and achievement difficulties where the individual desires to succeed but struggles with traditional learning methods, despite often being highly intelligent. In contrast, conduct disorder is marked by aggressive behavior, antisocial actions, family or environmental hostility. So keep this in mind as you're thinking about which might be which. ADHD is linked to cognitive and attentional deficits, whereas conduct disorder often involves environmental factors and a higher degree of aggressive behaviors. Both disorders do have a genetic component, but the role in the environment is much more significant in conduct disorder. Now let's examine some behaviors commonly associated with ADHD, and it's not unusual for ADHD to co-occur with anxiety and depression. Um, so here, in fact, many young people are treated with medications for both conditions, although it's important to note that medications for ADHD can sometimes worsen anxiety. ADHD has a global prevalence of 8 to 11%, and it's more commonly diagnosed in boys than girls. This may be due to the fact that boys are more likely to exhibit externalizing behaviors such as aggression, as we talked about earlier. Externalizing behaviors are often seen more so in boys, and internalizing behaviors are seen more so in girls. The symptoms of ADHD tend to persist beyond childhood. In most cases, studies indicate that 65 to 80% of individuals diagnosed with ADHD as children continue to exhibit symptoms into adulthood. Of these, 60% of adults still meet full criteria for ADHD, but are considered to be in remission, meaning that they have learned to manage their symptoms effectively. For example, behaviors such as fidgeting, irritability, and intense focus may continue, but individuals with ADHD often develop strategies to cope with these. In fact, these traits may sometimes contribute to success in specific career paths. There are numerous examples of successful individuals who were diagnosed with ADHD. So let's look at some specific behaviors and how they differ in individuals with ADHD versus those without it. So, for example, 65% of adolescents with ADHD tend to blurt out answers in class compared to only about 10% of individuals without ADHD. Again, fidgeting is very common and this behavior seen in children diagnosed with ADHD are almost at 75% compared to, again, only about 10% of kids without ADHD. Similarly, losing items is another frequent challenge where about 60% of children with ADHD have it, whereas only about 12% of kids without ADHD. So this information is quite old. You can see at the bottom there, it's from a study completed in 1990. However, this research really does still seem to support all of the facts that we've talked about here. When it comes to ADHD, there are notable differences between how it is presented in boys and girls. While ADHD is more commonly diagnosed in boys, it is often underdiagnosed in girls. A 2016 study examining ethnically diverse group of girls found that those with the combined type of ADHD exhibited more disruptive behaviors, while those with the inattentive type showed higher rates of comorbid diagnoses such as conduct disorder and oppositional defiant disorder. So girls with ADHD were more likely to experience co-occurring disorders compared to girls without ADHD. In addition, girls with ADHD, particularly in the inattentive type, are often viewed more negatively by their peers than girls without ADHD. This can manifest in behaviors such as forgetfulness, failing to follow through on social commitments. This is especially problematic during middle school years when peer relationships are very, very highly important. These girls may be perceived as socially undesirable or struggle with social interactions. Girls with ADHD may also be prone to anxiety and depression, which can sometimes be mistaken as the primary diagnosis rather than recognizing the underlying ADHD. Furthermore, girls with ADHD often experience difficulties in planning and problem solving, which is common in both boys and girls. As they reach adolescence, girls may also develop eating disorders or engage in substance use as a means of self-medicating or trying to manage their behaviors. The underdiagnosis of ADHD in girls is a significant issue because in adulthood, many women realize they were previously misdiagnosed with anxiety or depression while their ADHD went untreated. This lack of proper diagnosis can make them feel as though they're not improving, as though their ADHD was never addressed, despite their symptoms being an important part of the bigger picture. Historically, ADHD in girls has been overlooked, but growing awareness is essential to ensure that they receive the appropriate treatment and diagnosis. With regard to etiology of ADHD, it is largely influenced by genetics. Research, including adoption and twin studies, has shown a strong heritability estimate of between 70 and 80%, meaning that if a parent has ADHD, their child has a 70 to 80% chance of also developing the disorder. There are two dopamine-related genes, DRD4 and DAT1, have been identified as significant contributors to ADHD. These genes are associated with dopamine receptor and dopamine transporter functions. While there is support for DAT1, it is mixed. Both genes have been consistently linked to ADHD in numerous studies. Now, environmental factors do play an important role, particularly prenatal influences. So, maternal use of nicotine or alcohol during pregnancy increases the risk of ADHD in children, particularly when the aforementioned genetic markers are present. This highlights the interaction between genetic predisposition and environmental factors in the development of ADHD. Gene expression can be triggered or influenced by environmental factors when leading to the manifestation of the disorder. Neurobiological factors are also implicated in ADHD. Research has shown that children with ADHD tend to have smaller dopaminergic areas in the brain, particularly in the frontal lobes, the caudate nucleus, and the globus pallidus, when compared to children without ADHD. While specific brain regions like these are not essential to remember for these practical purposes, it's important to recognize that ADHD is not merely a behavioral disorder. It stems from differences in brain function. These brain differences are often why children with ADHD may perform poorly on tests or struggle with tasks requiring attention and concentration and impulse control. The efficacy of stimulant medications in treating ADHD further supports the neurobiological basis of the disorder. Stimulants work by targeting the dysfunction in the frontal lobe, helping to regulate attention and impulse control. If a stimulant medication does not work for a patient, it's likely that ADHD is actually not the underlying issue, as these medications are specifically designed to address the neurological differences in ADHD. So, further examining the etiology of ADHD, Perinatal and prenatal factors play a significant role. We have not talked about this yet, but low birth weight and premature birth have been correlated with increased risk of ADHD. Maternal use of tobacco and alcohol, as we discussed in our last slide, as well as exposure to environmental toxins are additional factors that may contribute. There is some evidence to suggest that food additives or colorings have a small impact on hyperactive behavior. There are also some children out there who have allergies to red dye and also have ADHD. So it's important to note that there are no evidence linking refined sugar directly to ADHD. So giving a child sugar will not automatically cause ADHD, which I think may be a common myth out there. Nicotine exposure, specifically from maternal smoking during pregnancy, has been shown to be associated with ADHD symptoms. Smoking can damage the dopaminergic system in the developing brain, leading to behavioral disinhibition, or what we might commonly refer to as poor impulse control. This is one of the reasons why it's crucial to educate families on the risks of smoking during pregnancy. When mothers smoke, nicotine passes through the child, and this can contribute to the development of ADHD symptoms. The parent-child relationship is significantly important and can really exacerbate ADHD. Parents often issue more commands and experience more negative interactions with their children who have ADHD because these children may forget instructions, they have difficulty listening, or engage in impulsive behaviors that may be dangerous or socially undesirable. In fact, studies showed that a child with ADHD may face 20,000 more negative interactions in an entire year at school compared to a child without ADHD. This can understandably contribute to feelings of frustration, leading to anxiety and depression in children with ADHD, and they just feel like they can just never get it right. That might be the attitude that they often have. Family dynamics, particularly when both the child and the parent have ADHD, can create a cycle of arguments, guilt, and shame. Both the parent and the child may feel inadequate due to forgotten tasks or unmet expectations, and in some cases, parents who have ADHD may struggle to support their child, even though they could offer valuable guidance by sharing their own experiences. These interactions, while they may complicate the situation, don't cause ADHD. However, they can either hinder or help the treatment process. Prior treatment involves understanding the unique challenges ADHD presents in family and finding ways to support both the child and the parent in managing the disorder. All right, so now let's talk about how we treat ADHD. The most common treatment for ADHD is stimulant medications. Some of the common ones that you've probably heard before are Ritalin, Adderall, Concerta, Strattera. These medications help reduce disruptive behaviors, improve interactions with adults and peers, and provide more positive feedback compared to the typical negative feedback children with ADHD so often experience. They also engage in goal-directed behavior and concentration and reduce aggression in approximately 75% of children. However, stimulant medications do come with side effects, such as the loss of appetite, weight loss, and sleep disturbances. These are common but not guaranteed. To address these issues, additional medications may potentially be prescribed to manage appetite, sleep, or anxiety symptoms that may end up as side effects from our stimulants. Newer medications, such as Intuitive, specifically target executive functioning within the brain. This term is commonly used in conjunction with stimulant medications, as they not only help to manage disruptive behaviors, but also work on improving cognitive functioning like attention and concentration, as well as organization. While medications play a key role in ADHD, it's the most effective when combined with therapy. This combination helps the child build self-confidence, develop mastery over their behaviors, and support the medication effects while addressing negative behaviors. Therapy also aids in improving social skills, such as reading, social cues, and managing interactions, which medication alone cannot address. Research has shown the benefits of therapy are long-lasting, whereas the effects of medication may diminish over time, and often medication really is most effective when it's taken right then and there. After the medication has moved through the system, it's no longer effective. So that's why medication such as the stimulants need to be taken on a daily basis to get the full effect. There are times in which the child or the individual, as they continue to grow and develop, they may need higher doses as they continue to grow, making therapy really an essential component for sustained improvement in managing ADHD. When we discuss the treatment of ADHD, it's important to differentiate between the psychological and the classroom interventions. In psychological treatment, parents are often trained to interact more positively with their children, being mindful of the number of negative interactions that they have. This helps prevent exacerbating issues such as depression and anxiety. Behavioral strategies are also employed where parents and therapists work together to reinforce positive behaviors, such as staying seated and not blurting out answers. Classroom treatment focuses on adapting the environment and the teaching methods to better support the child with ADHD. One effective approach is behavior monitoring, where educators track progress and reinforce appropriate behaviors. In the classroom, it's important to provide brief assignments with few steps, offer immediate feedback so that students can make quick adjustments, and use task-focused teaching strategies. This approach helps students stay engaged and reduces the frustration that often then leads to behavioral issues. Another key strategy is allowing frequent movement breaks. It is essential not to remove recess or physical activity, as children with ADHD need opportunities to burn off that excess energy. So, some strategies like taking away recess actually just make it so much harder for the child to focus throughout the day. So, we need to be advocates for these children, and we need to make sure that they are getting what it is that they need and ensuring that ADHD related needs are addressed in their IEPs to ensure that children with ADHD can succeed and maintain positive self-esteem, even when they don't always conform to the traditional learning styles. Now we need to talk about how ADHD differs from conduct disorder. Conduct disorder involves a pattern of behaviors that violate societal norms and the rights of others. Unlike ADHD, which stems from impulsivity or forgetfulness, conduct disorder is characterized by deliberate actions such as aggression, cruelty to people or animals, property damage, excessive lying, and these behaviors not just attempts to avoid consequences, such as a child lying to avoid punishment, but often include callous disregard for others. Individuals with conduct disorder may exhibit a lack of remorse for their actions, saying that they were sorry without genuinely feeling or understanding the harm that they caused. Related to conduct disorder is intermittent explosive disorder, which was introduced in the DSM-5. This disorder was characterized by recurrent verbal or physical outbursts of aggression that are disproportionate to the circumstances. These aggressive episodes are impulsive and unpredictable, often occurring without any clear trigger or stimulus. That's going to be very important. Oppositional defiant disorder, or ODD, involves a consistent pattern of defiant behavior, though it does not meet the criteria for conduct disorder, particularly in terms of extreme physical aggression. Children with ODD frequently display argumentative behavior, lose their temper regularly, sometimes multiple times a day, and consistently fail to comply with rules. They may deliberately provoke others, act hostile or spiteful, and often shift blame onto others, lacking accountability for their actions. ODD is often comorbid with ADHD, as well as learning and communication disorders. It's important to note that while disruptive behaviors in ODD are more deliberate, ADHD can typically diagnose more frequently in boys than in girls, as we mentioned earlier. Okay, now let's discuss the DSM-5 criteria for conduct disorder, focusing on what needs to be present. We're looking for a repetitive and persistent pattern of behavior that violates the basic rights of others, which has occurred over the past 12 months, with symptoms observed for at least 6 months. These behaviors can include aggression towards people or animals, such as bullying, fighting, or forcing someone into sexual activity. Destruction of property may also be present, including fire setting, vandalism, or intentionally breaking things. Other behaviors may include deceitfulness or theft, such as taking someone's belongings, breaking into homes, shoplifting, or manipulating others through conning. Serious violations of rules are another hallmark, which may involve staying out all night before the age of 13, defying parental rules, truancy, or just refusing to go to school. These behaviors must cause significant impairment in social, academic, or occupational functioning, and they need to be present across multiple environments. There are some key factors about conduct disorder. Substance use, often becomes prevalent in children with conduct disorders as they age, although it's unclear whether substance use precedes the disorder or occurs simultaneously with it. Conduct disorder is also commonly comorbid with anxiety and depression, and the conduct disorder typically develops before anxiety or depression. The prevalence of conduct disorder, again, is higher in boys compared to girls, with rates ranging from 4 to 16% in boys, whereas we get about 1 to 9% in the general population. Here we can see a diagram illustrating the development of conduct disorder. It shows how the neurobiology of the brain, psychological history, and social impact interact and influence each other. In the center of the Venn diagram, we see conduct disorder as the outcome, kind of like a perfect storm here where these factors converge, leading to the progression of conduct disorder and the associated psychopathology characterized by highly negative or antisocial behavior. When examining the etiology of conduct disorder, we must consider factors such as brain development, environmental influences, and genetics. Heritability plays a role, although not as significant as some other factors. Twin and adoption studies have provided mixed findings, often focusing on criminal behavior rather than conduct disorder itself, so the conclusions kind of remain inconclusive. Meta-analyses of twin and adoption studies over the past 3 decades suggest that 40 to 50% of antisocial behavior is heritable, even if a child has never met their biological parents. How interesting is that? They still may inherit antisocial tendencies. Early childhood is the most common onset for these behaviors, and the earlier they begin, the more likely they are to be linked with genetic factors. However, these behaviors manifest in genetic and environment, really, like we saw on the last slide, create this perfect storm of all these different factors interacting. For example, a combination of child abuse, low brain activity, increases the likelihood of developing conduct disorder, and this interaction highlights the importance of both neurological and environmental factors that shape one's behavior. As for treatment, children and adolescents with conduct disorder are often viewed negatively and may be labeled as quote unquote juvenile offenders. These individuals may be more familiar with local magistrates than peers without conduct disorder, making them less desirable to work with in therapeutic settings. So, how do we treat conduct disorder? Well, one of the most effective approaches is through family interventions, such as family checkups, which may set boundaries and reduce disruptive behaviors. We've got PMT, which is parental management training. This is a key concept where we teach parents how to reinforce positive behaviors from an early age while discouraging negative ones. Another highly effective treatment is multisystemic therapy, MST, and that delivers intensive community-based services not only in the home, but also within the school and the broader community. This approach may also involve collaborating with legal authorities, emphasizing restorative care rather than simply incarcerating the youth. MST focuses on treatment of the individual, the family, and the community, recognizing the interconnectedness of these symptoms in addressing conduct disorder. The trauma-informed context will explore how these treatment methods intersect with one another and the therapeutic approaches. Now we're going to shift over to learning disorders and autism spectrum disorder before wrapping up today's lecture. In the case of learning disabilities, there's often evidence of underdevelopment in a specific area, such as math or reading. To be diagnosed with a learning disability, the issue cannot be attributed to factors like intellectual disability, formerly known as mental retardation. It cannot be attributed because of autism, physical disorders, or lack of educational opportunity. It is important to note that while the DSM still uses the term mental retardation, the updated terminology is intellectual disability. If an individual has an intellectual disability, secondary learning disabilities are not typically considered. However, the individual has an higher IQ and is still struggling in specific academic areas, then perhaps maybe we will look into learning disabilities. People with learning disabilities usually have average to above average intelligence as measured by standardized tests. These disorders are often identified and addressed in schools. Parents may not always recognize the extent of the difficulty, as they may be helping children with homework at home, but might not be aware of how far behind their child may be in areas like reading or math. Whereas school counselors, it is important to be attuned to these issues, as the student's self-esteem may suffer if they are struggling academically. Statistically, reading disorders are more common in boys than they are in girls. So let's go over some specific regarding the DSM-5 criteria. Learning difficulties in basic academic skills, such as reading, math, or writing, are consistent with the individual's age, schooling, and intelligence are key indicators. This means we must assess whether the individual is performing at grade level in reading, writing, and comprehension. There must also be significant interference with academic achievement and daily activities. In the DSM-5, dyscalculia and dyslexia are no longer separate diagnoses. Instead, the DSM-5 now includes specifiers for specific learning disorders, which encompasses impairments in reading, written expression, and mathematics. So rather than diagnosing dyslexia as a separate condition, we now focus on learning disorders more broadly with specific areas of difficulty in whether that's reading, writing, or math. To diagnose a specific learning, communication, or motor disorder according to the DSM-5, we have the chart here. This comes directly from the manual, so I encourage you, if you'd like to take a moment and pause this video and go ahead and read through that. But a few key points to note are we previously discussed how specific learning disorders now include specifiers for dyslexia or dyscalculia, but these are now separate diagnoses. They are categorized as specifiers under the broader umbrella of specific learning disorders. Communication disorders, on the other hand, often involve issues with speech, sound, fluency, and are often related to language. Social communication disorder involves difficulty with understanding social cues, such as body language and tone of voice. Motor disorders, which fall under the communication disorders, may include conditions like Tourette's syndrome, developmental coordination disorder, stereotypic movement disorder. While these conditions are typically diagnosed in children, adults who had these challenges in a childhood may still experiencing linger deficits, which can sometimes be managed with medication. So if you're working with adults, it is less likely that you'll encounter these disorders as primary diagnoses, but you may see individuals who continue to manage these symptoms from childhood. To treat learning disabilities, especially reading and writing specifiers, multisensory instruction is often effective. This may include activities like writing letters in shaving cream or creating tactile shapes, engaging various different parts of the brain. For children preparing for kindergarten, readiness skills are emphasized, and instruction plays a very critical role in addressing reading and writing challenges. Providing additional practice, extra time, tailored exercises can help the brain compensate for deficits. For communication disorders, one program that has been proven beneficial is called Fast Forward. This program uses computer games and audio tapes to slow down speech sounds. Children with communication disorders may speak either too slowly or too quickly, causing their words to blur together. Fast Forward helps children practice speaking more deliberately, improving enunciation and clarity so that they can be understood by others, enhancing their learning process. In the case of intellectual disability, specific approaches would be used based on an individual's needs. Like we discussed, this used to be previously referred to as mental retardation. Within the DSM-4, the term intellectual disability has now been used to reduce stigma associated with that former label, which is often seen in the media and pop culture. Intellectual disability is defined by specific limitations in both intellectual functioning and adaptive behaviors, which are expressed in three areas: conceptual, social, and practical life skills. This disability is present from childhood and is typically diagnosed before the age of 18. Treatment for intellectual disability often involves residential care with small to medium-sized community-based facilities for both children and adults. Behavioral treatments are commonly used, particularly for children, along with speech and language therapy, and training in social and motor skills. Programs like Children Therapy Center focus on methods such as successive approximation, which teaches basic self-care skills like holding a spoon, toileting, and walking while holding onto a railing. Then applied behavioral analysis, ABA, is frequently employed to assess and analyze the behavior, helping individuals learn foundational skills and building upon them. Cognitive behavioral treatments may also be useful and help the individual with problem-solving skills. One particular mode could be cognitive behavioral therapy, CBT, And additionally, computer-assisted instruction has become more and more common in recent years, helping children with intellectual disabilities work on self-care and problem-solving skills through interactive technology, such as very specialized programs. So, with technological advances, these methods are becoming more integrated into treatment plans. And while you may not work directly with these disorders in your counseling practice, especially whenever it comes to adults, it's important to familiarize yourself with the range of disorders and treatments because this knowledge will enable you to understand your client's history and refer them for more appropriate treatment as necessary, especially if you're working with children in your practicum or internship. Now let's move on to Autism Spectrum Disorder, ASD. In the DSM-5, this combines several previous diagnoses such as Asperger's syndrome, autistic disorder, and pervasive developmental disorder, all under one umbrella. These conditions are now viewed on a continuum, similar to how we discussed schizophrenia spectrum disorder. Research no longer supports the idea of distinct categories as they are common deficits across all individuals with ASD. However, the level of functioning does vary, which is why the disorder is now classified along a continuum rather than a separate diagnosis. Specifiers for ADHD may include conditions such as with or without intellectual impairment, language impairment, or catatonia. Let's take a moment to review the DSM-5 criteria for autism spectrum disorder. I encourage you to pause the video and take a look. While assessing this disorder, we need to pay close attention to social deficits, such as difficulty with eye contact, repetitive behavior, and these behaviors are often described as stereotyped or repetitive behavior, and these routines tend to be very important for individuals with ASD. The term perseveration is frequently used to describe these repetitive behaviors or preoccupations. It's kind of like the person gets stuck in a rut or kind of in a loop is a way to think about it. Additionally, sensory input issues are common. For a diagnosis, symptoms must begin in early childhood, though it's not uncommon for high-functioning individuals to be diagnosed in adulthood, often having a slippery kind of slip through the cracks in childhood. This can be challenging as most treatment programs are geared towards children and there are fewer resources for adults. In such cases, adults may need to seek treatment through state waivers as opposed to early intervention programs available for children. And now that we've reviewed this criteria, let's dive a little bit deeper. Autism spectrum disorder is associated with significant challenges in navigating the social world. A difficulty often referred to as the theory of mind refers to a person's ability to understand that others have different thoughts, desires, beliefs, and emotions. Individuals with ASD often struggle with joint attention, which means that they have trouble focusing on shared activities or maintaining relationships and conversations. For example, an individual with ASD may focus on one part of a person's face, such as the mouth or the eyes, without fully understanding the social cues others are expressing. This difficulty in interpreting emotional signals can make it very challenging to understand the feelings of others. Theory of mind is essential for engaging in social interactions as it allows us to empathize and understand others' motivations. For individuals with ASD, in understanding it is often impaired. They believe that others feel the same way that they do because that is their only frame of reference for interpreting the world. Typically, the inability to develop theory of mind occurs between the ages of 2.5 to about 5 years old, and children begin to engage more socially. However, children with ASD may not achieve milestones, and this lack of understanding of others' perspectives also includes developmental concepts like object permanence and facial recognition, and particularly that's evident in individuals with more severe forms of autism. Children with autism often experience communication deficits, with early language disturbances being very common. Many children with ASD require extensive speech therapy. One characteristic feature of ASD is called echolalia, which refers to the immediate or delayed repetition of words or phrases that they have heard. Pronominal reversal is a common example where children refer to themselves in the third person using he or she instead of I or me. Additionally, children often use language very literally, lacking an understanding of abstract expressions, and this makes understanding and interpreting literary works with abstract concepts very, very challenging for these folks. Repetitive and ritualistic behaviors are common in children with ASD. They often become upset when their routines are disrupted, which can lead to an increase in problematic behaviors. Obsessive play is another characteristic where children become fixated on specific objects or activities such as a favorite character, say, for example, trains or the alphabet or dinosaurs. They may also engage in repetitive body movements like rocking or hand flapping. Children with ASD may form attachments to inanimate objects like keys, rocks, or specific toys, and may show distress if these objects are taken away or lost. Comorbidity is very common in children with ASD, particularly with low IQ of about 170. However, this is not always accurate because most intelligence tests are normed on children without ASD, meaning that the results may not reflect the true abilities of a child with ASD. Children with intellectual developmental disorders often score poorly on certain parts of IQ tests, especially those assessing language and abstract thinking. On the other hand, children with ASD may perform better in areas such as math, abstract thought, or sequential logic. Regarding prevalence, approximately 1 in every 110 children are diagnosed with ASD, though this number can fluctuate based on various environmental and diagnostic factors. ASD is found across all socioeconomic, ethnic, and racial groups, and it is consistent worldwide. The diagnosis remains stable, and ASD is a lifelong neurodevelopmental disorder. In terms of prognosis, children with higher IQs who develop speech before the age of 6 tend to have better outcomes. This is in contrast to nonverbal children who often face greater challenges in interacting with the world and gaining independence as they get older. When discussing the etiology of ASD, it's crucial to address historical stigma, particularly this misguided theory of the refrigerator mothers. These mothers were believed to be emotionally distant or cold and were responsible for causing autism. This theory has been debunked, and the stigma still persists today in some circles, but this is not a cause for autism spectrum disorder. When discussing the etiology of autism spectrum disorder, genetic factors do play a significant role. Heritability is estimated to be around 80% or 0.8, with twin studies showing concordance rates ranging from 47% all the way to 90% for monozygotic twins. One notable genetic anomaly is the deletion on the chromosome 16, which has been frequently associated with ASD. This information is drawn from the textbook and highlights the genetic underpinnings of ASD that serve to refute outdated theories, such as, like we just talked about, the refrigerator mother hypothesis. This concept, which suggests that autism was caused by emotionally distant or neglectful mothers, profoundly affected parents in the past. Now, recognizing the genetic basis of ASD helps to dispel such harmful stigmas from decades ago. Treatment for autism spectrum disorder was generally more effective with psychological interventions than with medication, although medication can definitely be used to manage certain behaviors. Early intervention is absolutely key, as developmental disorders tend to have better outcomes when addressed at a younger age. The earlier we provide treatment, such as in-home services, speech therapy, and social skills group, the better chances of achieving positive outcomes. Intense conditioning, where positive reinforcement is provided for prosocial behavior, has shown promising and encouraging results in helping children learn social skills and behaviors that may not come naturally to them. Parental training and education is absolutely essential, enabling parents to better understand their child's needs, assist with interventions, and recognize that the child's behavior is not their fault. Pivotal response treatment, which focuses on increasing the child's motivation and responsiveness, is often used. This approach works on improving the child's overall engagement rather than just targeting specific behaviors. Techniques like joint attention interventions and symbolic play therapy are also important as they help foster expressive and social skills. While medication can be used to manage aggressive behaviors or those with poor social outcomes, it is typically reserved for situations where behavioral issues are severe. For example, Haldol, an atypical antipsychotic, is commonly used in adolescents with ASD to reduce aggression and stereotyped motor behavior. However, it does not improve language or interpersonal skills. It primarily helps to control anger and aggression, which is especially important in children with ADHD as they age and they display more dangerous behaviors. This overview, I know there was a lot in this lecture. It provides a very broad understanding of childhood and neurocognitive disorders, which are rooted in both brain development and decline. So this foundational knowledge is going to support the work that you do throughout the remainder of the semester. So that's it for this lecture, and I'll see you in the next one.